Welcome to the Critical Care Obstetrics Podcast. I'm Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics, and I'm here with my partners, Julie Arafeh, our Simulation Director, and Suzanne McMurtry Baird, our Nursing Director. Suzanne's also joined by her snoring puppy, Dolly, who's thrilled to be here today to learn about our pet peeves. So in this series, each of us is taking an episode to talk about our pet peeves, and today is my turn. Before we get into it, I want to remind you guys to go find us on YouTube. You can watch this or listen to it on YouTube as well at Critical Care OB Podcast. And if you want more of this kind of content, you can find us on patreon.com/CCOB, where we do more podcast type presentations with audio visual aids. We can do slides and graphs and all kinds of things. And we have the opportunity to have more interaction with us with live Q&A sessions as well. If you want to learn more about the Critical Care Obstetrics Academy, that's on our website at clinicalconceptsinob.com. Okay, y'all ready to hear my pet peeves?
Yes.
Okay,
Yes,
I think
I
I told
can't
you the story already that when I was in the 7th grade, when I learned about what pet peeves were, and this squashed my interest in creative writing, what little their interest there was, because I didn't actually know what a pet peeve was. And I wrote a whole essay describing what my pet peeve looked like, what it ate, how I took care of it, all of the things. And then I had to redo the assignment because they weren't happy because that wasn't a pet peeve. And I'm like, well, I thought it was pretty creative, but anyway.
I think it was really creative, but it
Very
also
creative.
I'm with Julie. I think it spoke to the need that you needed a pet.
Yeah.
Yes.
I think you needed a pet.
Yeah.
I did.
Thank gosh you
Name
got
my
one
next
now.
cat Peeve. Okay.
Well, at least it won't be peanut butter.
Well, Peanut Butter was named for me. He came named, and he was 6.5 when I got him. So, and he definitely knows his name. So I just couldn't change it.
You had to. Yeah.
Anyway.
Yeah.
Okay.
So
what's your pet
y'all
peeve?
I know you've heard this one pet peeve, but I have been talking about this pet peeve for many, many years, and I talk about it in lectures, and I've talked about it on the podcast. So some of you may be knowing what it is, but give me one vital sign. Just give me one vital sign and not the whole set of vital signs. That's one of the worst things you can do to me. Dr.
You
Martin,
should have had
her
us
blood pressure is I should have had you guess.
Yes.
Yeah.
I could have guessed that one.
Then somebody can call me and say, Dr. Martin, your blood pressure is 90/40. And I'll say, what's her heart rate? Oh, give me a minute. And they go back and come back. Her heart rate's 130. What are her sats? Give me a minute. Like, don't even bother to call me until you've done a complete set of vital signs and an initial assessment for that matter. Because one vital sign in isolation doesn't mean anything. Give me a set.
Mm-hmm.
Well,
right? Am I alone in this?
Okay. Well, I would probably add to your pet peeve, because I think this is you as well. It's not just one vital sign. It is what has been the trends too.
Yeah.
So
Yes.
that I know is important to you too. So your
100%.
pet peeve really is about giving you incomplete assessment around vital signs.
Right. Like, what's
Right.
my natural next question going to be? What should anybody's natural next question going to be? And you should be thinking that. I mean, that's, because usually we're talking about in this scenario, it's nurse to physician. So as a nurse, when you're getting a set of vital signs or when you're doing an assessment on the patient, what curiosity do you have about your patient? Like, what do you want to know about what's happening? Well, if you've got an abnormal vital sign, what were her last vital signs? How was that different or the same? What about the rest of her assessment? If she's got a low blood pressure or you're concerned it might be low, well, then how is her perfusion? What's her mentation? How does the fetal heart rate tracing look? All of these kind of things are going to be able to give the picture so that we can come up with a plan and a differential diagnosis and all of the things that need to happen more efficiently, right? Because yes, I can sit on the phone and wait for you to go do the rest of the vital signs, or those could have been done before I was called, so that then our conversation is an actual conversation about what might or might not be happening with the patient.
I think it's hard to, when you're the nurse at the bedside to think about, because you're seeing everything and you know everything. So you have to step back and think, how do I paint the picture of this patient for the physician so that they understand why I am concerned? So when you step back and think of it that way, you wouldn't just, if you're painting a picture, you wouldn't just put one dot there. You would have to fill in more information so that you actually give a very clear picture. So it's not just going to be blood pressure. It's not just going to be the heart rate. It's not just going to be the fetal tracing. It's going to be the picture. And it doesn't mean their history, because that drives everybody nuts. No one needs to know all the history unless it's relevant to what you're saying. So that's how I kind of always think of it, is the picture. What picture do I need to paint for the physician to tell them so that they are as concerned about the patient as I am?
Well, and I would anticipate that if you got a more complete picture, especially about a concerning patient, then you would feel more of the need to come on in too, or to come to the bedside to do your own assessment. Am I right?
Yeah, I mean, knowing more information is always better and helpful, but I don't have to know every single thing. But I need to know enough to understand why I'm being called and to understand what your concerns are. And then we can make a decision about whether what needs to take place next, which could include coming to the bedside, or it could include ordering more evaluation or doing some other action, depending on what I'm being called for, right? So
Right.
and I trust nurses' intuitions. I really want to know. And many times, back in the old days before it was more structured, and nurses maybe were not as comfortable saying, I need you at the bedside, or we weren't there was no one in the hospital a lot of the times, and it'd be the middle of the night. I was grateful when they would say, I need you to come in to see the patient because. And if they didn't, I would often interrupt them in the beginning and say, before you go any further, are you asking me to come in to the hospital? Because if so, I'll begin the process of getting ready and coming in while we're talking. Like, I'm not going to wait 10 minutes. I can be having this conversation as I'm putting my shoes on and relocating to the car to come in, or coming in from the hospital or wherever I'm at. So that clear communication is really important. But I trust what the nurse is saying, but I also want to understand what's backing it up. For example, if a nurse calls me and says, something's just not right, I don't like what's happening here, I need you to come evaluate the patient. That is completely valid. But what's not right? Is it not right that you think she's bleeding too much? Is it not right that you think she's just not responding the way she was an hour ago? Is it not right that her blood pressure trends are higher than they were, or that her heart rate trends are lower than they were? Like, what is not right? And that helps me understand what I'm going to be doing when I get there, what kind of, maybe some things need to happen while I'm coming in, those kind of examples. So more detail to justify is better. And if you're not sure, my advice, and then I want to hear the nurses give the advice, but if you're not sure, initially I would say, do a complete assessment with a set of vital signs and get someone else to take a look at the patient with you if you're not sure either what's going on or what needs to be communicated. So that's like the bare minimum. What are y'all's thoughts on that?
Well, I agree, because I think that when you're not sure component comes up when the physician's not in house, and especially on the night shift, and having a buddy, having the charge nurse, having someone come and validate what you're seeing. It doesn't have to take long, but come and validate. We work as a team, and come in and say, I agree with you. I hear crackles in her lungs. I agree with you. Her blood pressure is trending in the wrong direction. Her bleeding is too much, or, you're seeing that amount go up. Then it also gives you more confidence than to call a physician at 2 a.m. in the morning, or whatever it is, if you have somebody come in and check that patient with you.
Yeah.
And it gives you more, it may give you another perspective too. It may be that another perspective is, I think this patient's doing great.
Yeah.
or here's why, and let's talk about it,
Yeah.
so on, depending on what it is.
Okay. You want to hear my next
Totally
one?
agree. Yes.
Okay. This is what drives me nuts. When physicians are presented with a different way of doing things, and their response is, well, that's not how I was trained. Because unless you are in training, your training is probably out of date. And there's probably been something new learned or discovered or whatever since you were trained. My training was completed 25 years ago. Well, let me rephrase that. My formal training in terms of my fellowship was completed 25 years ago. I'm pretty sure there's been some movement forward in the world of obstetrics and women's health since that time. And if I relied on only what I was taught in my training, I would be an incompetent physician, in my opinion. So,
Well, that would go for any profession, right?
Oh, yeah.
What was it that Dr. Lexi Hill said, she goes, we're all learners. We're, on a continuous learning path. And of course, that's the way we feel. We are
Yes.
on a continuous learning path. So if you took fetal monitoring back in the 70s or
Bingo.
the 80s or the 90s, you probably need to have another course.
Yep.
not probably.
I mean, nurses have to
You definitely need to have another
Yeah.
course.
I mean, nurses are required to do it every 2 years, and some physicians don't even do fetal monitor training.
Correct. So, I mean,
Well,
but it's like, go ahead, Julie.
Every hospital is as unique as a thumbprint. So the way that this hospital has set up how to do something may not have to do with anything more than this is the way it works the best there.
Yeah. Yeah. Now, it's one thing I'll commonly be, you know what, when I was trained, this is how it was. And that's like let's all understand how things used to be kind of perspective. And look how far we've come. I mean, things are very, very different. That's different than, look, I was trained to do it this way. I was trained that is hyperstimulation. Don't talk to me about tachysystole. Okay. And if you don't know what I'm talking about, then you need to take a fetal heart rate monitoring class. So
Yeah.
we have to be continuously evolving. And the excuse of that's how I was trained or that's not how I was trained, frankly, just makes you look dated and inflexible and unresponsive. And it's not a good look. We need to be willing to change, willing to learn. I'm sure I've been guilty of it. But right now, that's a pet peeve of mine. I don't want to hear how you were trained. I want to know you were trained, and I want to know how you're staying up to date.
Yes. I mean, I would hate to think that I ran Pitocin the way I first ran Pitocin when I first got out of nursing school. It was really an aggressive time of Pitocin action. We would start at 5 and turn it up by 5 every 15 minutes until we got to 20, and then we would start going 2.5.
And once upon a time, weren't you also counting drips, like literal
Yeah,
drops to
well-
get infusion rates?
Oh, yeah.
Well, actually, that was in nursing school. I didn't really do that when I got
I
into
used to.
practice. Yeah.
Oh, God. I love the IV pump. I hated counting those drips.
Think about that, new nurses, not even new nurses. And you didn't have a pump determining your rate. You're counting the drips to determine your rate.
Oh, yeah.
Yeah. I was trained to do it, but I don't remember how to do it.
I think that's where a checklist comes in, because it is impossible to think that you are going to remember everything. So the checklist is just your touch base so that you kind of can organize your thoughts and not be distracted by process.
Yep. Well, my next pet peeve is a perfect segue on this. And it's kind of a branch of what I was just talking about, but I think it's separate. Okay. And it's a segue. Your comment, Julie, is a perfect segue. Okay. So you're in a situation and, my pet peeve is this. My pet peeve is when people say, well, this is how I do it. Okay. And the situation is this. how do we manage X at this facility? Well, let me show you how I do it. How do we let the nurses know, like I'll think of an outpatient setting. How do we let the nurses know that this patient needs to be scheduled for this appointment or whatever? And it's not, this is the process in this institution. It's, well, I'm not totally sure, but let me show you what I do. So everybody has their own way because
Yeah.
there is no one way. They've all created their own way. And my response is always, well, but what's the way?
Yeah.
Not how do you do it? How is it done?
Yeah.
Is it not exist? Is there no way defined? Is there no policy, procedure, guideline, whatever that defines this? And so we've all kind of figured out our own way? Or is it a way that's defined that doesn't work? So we've all figured out our own way? Or is there a way that's defined, but no one knows what it is or where to find it or how to use it? And so they all find their own way. Like, what is it? Because this million different ways of doing the same thing, I don't handle well. That's definitely a pet peeve of mine.
Well, especially, and it's more than to me a pet peeve. It is safety, and
100%.
in
Oh, yeah.
in an OB emergency, that becomes the safety issue. Is when
Yep.
everybody does it differently, and not based necessarily on best practice recommendation or evidence. Like we
Mhm,
don't have a
mhm.
lot of evidence for some things that we do in obstetrics because there has been limited research on
Mhm.
how and what the best is. But there is something out there in OB emergencies that is telling you this is the best evidence that we have and these are best practice recommendations. And I don't really care how you were trained, and I really don't care how you did it back in 1970s, or I really don't care how you do it. This is the way we do it here, and this is why. And I should know the why.
mhm.
Yeah. I think it's hugely important because if you have people heading off and doing different things in an emergency, that just produces chaos because
Yep.
that group think, that shared mental model is not there. And the shared mental model that you have as a team when you're responding to an emergency is huge. Even if you maybe don't have as crisp of communication as you want, or the role delegation gets screwed up a little bit, as long as everybody's on the same page, you can work through those things. But when people are all off doing their own thing, and I would venture to say it's probably because this process was written and never tested in simulation. And the staff realize immediately, okay, how are we going to do this? Not going to work here. So they all begin to figure out their own way of how to get something done
Mhm.
when the process has never been tested.
Well, and
I mean, we're good at that.
well, and I'm talking not just in emergencies. It absolutely happens in emergencies. An example I can think of in an emergency situation is, how do you guys notify the blood bank that you need blood right away? Well, what I'll do is this. There
Mhm.
is no one way to do it. Okay.
Yeah.
And that's a great emergency example. But it also happens like in the non-emergency setting, just in routine stuff. Like, how do you identify who the surgical assistant is going to be for this case? And he asked 10 people and there's 10 different ways. How do we know?
Yeah.
Like that there's so many different ways this happens. You guys are going to start noticing this now. So I want you to start paying attention, like in your own life, like not even medicine. Well, this is how I do it. But in medicine, the consequences can be pretty significant, you
Yeah.
know?
Yeah.
Well, I think yours are all intertwined too, Stephanie. Your three
Mhm.
pet peeves can be really intertwined
Similar
in
themes.
how, similar themes on how patients are being managed and everything.
Yeah.
So I think it's interesting that, and we didn't know what any of our pet peeves were going to be. We didn't tell each other, so it is interesting that we're all different, but
Mhm.
yet I could have guessed. I could have guessed your first one though.
The first one you probably could have, because I say it so much all the time. Okay, my last one. I've got many more, but I'm going to end with this next one because
You're
it's
going
one
to
of
do
the.
4? We only
Is that
did
okay?
3, but yeah.
Yeah.
Well, I kind of felt like the last two were pretty similar.
Yeah.
I
Okay.
felt like they were kind of part of a theme. But the last one you guys will know as well. It's probably your pet peeve too. Waiting too long to call an MFM.
Oh, yeah.
Ah, yeah.
Or not
Yeah.
calling them, period.
Or not calling at all.
Well,
and that includes not involving us in postpartum care.
Yeah. I think that goes to the physicians. I really do. I think
does.
that, I've heard of nurses just calling MFMs, and I don't think it's their role to call MFM unless it's an emergency that's been defined. This is how we're going to do it, and an MFM is called at this point. A physician needs to make that physician-to-physician contact and discuss the consultation. Not the nurse to the MFM.
But you know what can happen is the nurse can lean over to the physician and say, our checklist says we can call an MFM consult. Would you like one?
Right. And I've done that too. I have definitely been in a situation where I've said, would you like for me to call the MFM? Absolutely.
Yeah.
And I've never had somebody say, no, I don't want them there.
Yeah.
In my stuff, in my business. But that's where ego sometimes can play a role in not doing something nurse to nurse, physician to physician. It's not about me. It's about what's best for the patient. But if you have that document that backs you up, then you may go ahead and do that action. I mean,
I see a lot of reasons why MFMs are late to the game. And some of it's ego. Some of it is, I don't need them. I don't want them. There's no role for that. I got this. Much of the time, it's not, it's all the stuff we preach, which is not recognizing how sick your patient is until it can't be ignored anymore. And then we're somehow expected to come in and rescue the situation when we should have been called hours, if not days ago. I mean, a classic example, I remember a case so distinctly. One day I get called into the operating room to a hemorrhage situation, and I walk into the room and I know that this patient is about to code, and it is crystal clear that she is in DIC. And I essentially scrub in and I said, look, I'm taking over. This patient is in DIC. She's about to code. And they're arguing with me that that's not actually about to happen. But her blood is water and it is not clotting. It's all over the place and it's not clotting. It's very clear she's in DIC. But it was because they completely underestimated what was happening. They didn't recognize it. And then there was ego, of course, because then I come in and then they don't even want to admit that what's happening is actually happening. That's an extreme example, but it's not uncommon. You talk to MFMs and that kind of stuff is happening all the time, right? So I think it's ego, but also not recognizing what's happening until it literally can't be ignored. She has to be intubated. She's seizing. She's, hemorrhaging to death, whatever it may be. Some of it's not having availability of MFM and therefore waiting too long to get them where they need to be so they have access to the right specialty. Like, we wouldn't allow a patient with a known or suspected myocardial infarction to stay in a facility without a cardiologist or an interventional cardiologist who can do the necessary procedures. We would stabilize and transfer, I would assume. But we do this in OB. Well,
I think it could also, your pet peeve could also be applied to a hospitalist role as well.
Yes.
That maybe the hospitalist would feel that they should have been notified sooner.
Or the intensivist before the patient's in respiratory arrest. Yes.
Right, exactly.
Yeah.
The ICU team, nursing, it could go back and forth. The charge nurse should have been notified sooner, or, somebody I should have known. Yeah.
But I think this is an example of you've got to know what your resources are and use them. If you have an MFM, you need to use them. And if they're not willing to come into the hospital and see a patient, that's a whole different story. Okay. That's a whole different issue to address. But I would say if you have a maternal-fetal medicine doc, take advantage of the fact that you have a maternal-fetal medicine doc and don't wait until your patient is crashing to get them involved. The sooner the better. And if they're not receptive to that, that's a whole nother issue. But assume that they're
and
receptive.
that's putting the M back in
Yeah.
MFM, you know,
Yeah.
getting them
Yes.
involved in maternal care and not just for ultrasound, you know?
Yes.
I
those
think
are
it
my pet
also
peeves.
highlights that discussion and learning, because when you talk to anesthesiologists, they're going to tell you when they want to be called in. If that respiratory rate goes up, no one wants to do a stat intubation on a pregnant patient.
Right.
And I think just that if the MFM can even call into the simulation, you can call that MFM in the sim just like you would do in an actual case.
Mhm.
And then you can patch them in and say, is this an appropriate time? What information did you need? When would you like to be called? You know, and you can figure out all of those things, and you can let the OB know that, this is another person, another brain to come in and help you.
Mhm.
It's not that someone thinks you can't handle it. It's that another brain is helpful.
Yeah, exactly.
Exactly right. We said that at the same time.
Yeah.
So I'm getting all irritated just thinking about my pet peeves.
I know. I'm getting irritated for you.
Well, this has been really fun. I actually learned a lot of from you guys about your pet peeves and lots of other stuff. So hope you guys enjoyed listening to this too. Thanks for listening. Don't forget to subscribe and leave us a review. You can learn more about our academy and our courses that are offered online at our website, clinicalconceptsinob.com. We're on YouTube at Critical Care OB Podcast. We're on Patreon at patreon.com/CCOB, LinkedIn and Facebook, Clinical Concepts in Obstetrics, and Instagram at Critical Care OB. Reach out to us. Let us know if you've got ideas for podcasts or questions you want answered. And thanks for supporting us.